first speaker is Dr. Francine Hosking. She's a Neonatal Fellow at the Royal Brisbane and Women's Hospital in Brisbane, and she also works at the Mater Hospital. She works with neonatal retrieval medicine and is extensively involved in the retrieval of babies throughout Queensland. Dr. Hosking's research interests include the prevention of neonatal infection and optimisation of antimicrobials. Dr. Hosking began her career with a Bachelor of Science with a major in psychology, and part of her ongoing interest includes the human and psychological factors that are involved in research implementation and optimisation. So I'll pass across to Dr. Hosking.
Thank you, and thank you for that introduction, Susie. And welcome everybody to the talk tonight. Part of what I'm going to talk about is antimicrobial optimisation in neonatal patients. I think this picture is actually somebody kicking COVID, but I thought that it was also quite a good crossover to how we feel about infection prevention and antimicrobial optimisation in our neonatal patients as well. And I like to think that's a neonatologist there. So I guess a little introduction about neonatologists. We're an interesting bunch. In fact, you rarely see us unless you come to the neonatal intensive care. We tend to stay very much in our little neonatal realm. And one thing that people should know about us is how much we hate infections. So we have this really high level of anxiety about the transmission of infections to our babies. And you may see some of the doctors or nurses get close to rugby tackling people at the door if they so much as cough or sneeze, knowing that even a common cold could potentially kill one of our fragile neonates. We're clinically attentive to hand washing, and in fact it's seen as an absolute outright failure in the neonatal department if our hand washing audits are less than 100%. And I think that's rivaled only by infectious disease physicians themselves. We use aseptic technique for almost anything that we can. And as you can see, we often see us dressed up in these sort of outfits fairly commonly in our unit. And in fact, even the insertion of cannulas we do under a semi-aseptic technique with sterile gloves. And we get very nervous about other teams coming and touching our babies who may not perhaps have the same adherence to infection control protocols that we do. So why are neonatologists so crazy about infections? So we know that our neonates are extremely vulnerable to infection. So they have very poor immune system as a result often of prematurity. Their skin barriers are not formed fully, so there's a very easy pathway for infection. And also we tend to add to the problem by inserting numbers of devices, whether that be indwelling catheters, cannulas, umbilical catheters, plastics when we're intubating. And the thing that frightens us the most is that neonates tend to have extremely poor clinical correlation when they're unwell. They don't always spike a fever. They might just have a bad day, in inverted commas, which always sinks our heart when a nurse tells you the baby she's looking after is having a bad day, because often that's the only sign that we might have. These babies have very non-specific clinical signs. But we know that if a baby does develop sepsis or other infections, that the death rates can be extremely high. And in fact, the highest rates of death from serious infection are in the neonatal period. So this table you can see here along the bottom is age in years. And it's looking at the incidence of sepsis as either a principal diagnosis or as an additional diagnosis. And you can see there's this really high spike in that less than 4-week-old group. So under a month of age, there's a much higher incidence of sepsis, which then sort of slowly starts to trend up again as you age. And the mortality rates in sepsis, as we know, can be shocking even when treated, and can be up from sort of 10 to 20%. The problem that we have with adult, paediatric and neonatal patients is that sepsis itself can cause quite significant changes in the body's physiology, and we get this physiological variation in sepsis anyway. They get hemodynamically compromised, they can become very edematous, they get these large fluid shifts, the protein binding can be altered significantly, and a sick patient can have increased, decreased renal excretion, increased or reduced liver function. And all of these things affects the drugs that we're using to treat sepsis. But in the neonatal patient, we have all of these things, plus this overlaying maturational effect. So many of our babies are premature babies, and they range from our very youngest to sort of 23 weekers through to term babies, but certainly the under 28 week group have quite significant maturational delay. They have a poorly functioning immune system. Their renal and liver function is also very poorly functioning. And so many of the drugs that we're using may not work adequately or can reach toxic effects very easily. The other problem, of course, is that we have very few decent pharmacokinetic studies in neonates. And in fact, most of the studies that we have are extrapolated from adult or pediatric studies. And in many ways, we know that there are certainly crossover effects, but it's a very difficult population to study. The patient heterogeneity is extreme. It's very difficult to find a number of babies with the same presenting physiology, the same gestational effects, in order to actually study some of the pharmacokinetics adequately. And many of the studies that we have are small sample sizes and are largely opportunistic studies. So there's certainly a gap, I think, in the literature here for decent, well-designed pharmacokinetic studies. So moving on into talking a little bit more about sepsis in neonates and what we actually are dealing with in terms of optimizing antimicrobials. So we tend to break infection in neonates up into early and late onset sepsis, and I'll mainly talk about early onset sepsis just because of the types of drugs that we use are different. And in that early neonatal period, in the first 24 to 48 hours, most of the serious infections that we find tend to be not particularly wild and wonderful. They're the things like your GBS, so strep infections, E. coli infections, and it makes sense. A lot of these are commensals of the maternal vaginal tract, and so many babies who have sepsis have had either premature rupture of membranes or prolonged rupture of membranes, allowing for some of these organisms to penetrate around that amniotic sac. And, you know, there are a couple that are less common, but we still cover with because they can be devastating, and that's things like listeria. So our common antibiotic regimes that we use are pretty simple and straightforward. We usually use a penicillin and a cephalosporin, or a penicillin and an aminoglycoside such as gentamicin. So I'm going to talk a little bit about gentamicin tonight, and that's because it comes into one of the studies that Susie and her team have been running and that I was involved in out of our nursery. So gentamicin is a pretty common drug in our nurseries. We use it frequently for both prevention and treatment of neonatal sepsis. And it tends to be a pretty standard dosing protocol, which is dependent on gestational age. So the younger you are, the less frequently you're dosed because of your renal excretion. So a 23-weeker will probably have a 36-hourly gentamicin dose, whereas a term baby will have a 24-hourly gentamicin dose. And then we make dose adjustments based on therapeutic drug monitoring. So we usually do a trough level before the third dose. And if that trough level is less than 2, then we will continue to treat with gentamicin. And really what that trough level is telling us is looking for toxic effects or poor excretion of the drug. And we know that in itself can be dangerous to our neonates. So gentamicin usually covers the sort of Pseudomonas, Enterobacters, Klebsiellas. It is important to sort of do this therapeutic drug monitoring, as I sort of touched on. It does reduce the risks of those supratherapeutic drug toxicities. So things like ototoxicity and nephrotoxicity are things that we certainly worry about. But also keeping drugs within a therapeutic drug range, makes the eradication of the desired pathogen more likely, and possibly can reduce the amount of drug-resistant pathogens that we're seeing. We know that antimicrobial resistance is coming for us. Certainly, we don't see large amounts of it in our nurseries yet, although we get the MRSAs and the ESBLs, certainly. But what we're seeing from overseas is becoming quite frightening. Certainly, in some of the African and European areas, we're starting to see quite significant antimicrobial resistance. And resistance to aminoglycosides can be sort of up to almost 70% in some areas. And third generation cephalosporins is over 80%. So we really do need to start thinking about how we're dosing our patients, whether that dosing is adequate and whether it's optimized. So therapeutic drug monitoring, we've established it's pretty important, but it does have a burden of care. And it's got a burden of care, particularly, I think, for our smallest neonates. You can see a little baby there on the screen who has a paediatric blood tube next to it there. So that is not an adult tube, that's a tube about this big. So that's a very small baby. The nursing time is a consideration when they're having to do multiple prolonged sort of sample takes on babies. It can be very distressing for the patients and the caregivers to see their babies having blood samples taken frequently and often with great difficulty. And it requires somebody very skilled, particularly in our small babies. We can't just have anybody taking blood out of these fragile babies. So skilled operators are difficult to come by. But ultimately as well, many of the blood samples that we take in neonates are by heel prick, even in our small babies. And those heel pricks are really terrible for babies' feet. The volumes of blood that we take for therapeutic drug monitoring in neonates are small and to us seem like nothing, but can be quite substantial. So for a 500 gram baby, which is the average size of a 23-weeker, which we frequently get in our nurseries, they have an average blood volume of 100 mils per kilo. So their total blood volume is around 50 mils. So for those of you that are going to have a drink after the symposium, this will be relatable. So that's just over the size of a shot, if you're so inclined, or half a glass of a standard red wine, which you won't look at in the same way now. So often for therapeutic drug monitoring, we might require multiple samples. So, even if it's only 2 samples from this small baby, that's 1 ml of blood. And that's equivalent, if I took blood from one of us, of around 100 mils of blood. And you can imagine that would probably be quite confronting for most of us if somebody took 100 mils of blood out of us. And we're talking about one blood test here for one antibiotic. So we're doing multiple samples daily on these neonates. So we know that we really want to reduce blood sampling. We know that over time, the blood samples that we take do cause anemia in these small babies. And there are obvious advantages in reducing the amount of blood, both from a physiological point of view, but also from a patient and caregiver point of view, and also for the nurses. And these are actually some of our lovely nurses who work in the intensive care over at the Royal Brisbane. Microsampling itself, has the potential to reduce the burden of care of blood sampling. It's not commonly used in the neonatal setting, although in this picture you can see, some of you may be familiar with the neonatal screening cards, which is a heel prick and a blood sample. And I guess that's sort of, in its most crude form, microsampling. It's using dried blood spot testing. But microsampling in this way is not effective for measuring things like drugs and toxicity levels. And so we were approached by Susie and her team about the possibility of potentially using microsampling techniques for measuring therapeutic drug monitoring in our neonatal population, and in particular in gentamicin, which is an antimicrobial that we use very frequently. So it was going to be potentially quite easy to recruit and to get patient data for that. So the options study, which is a bit of a mouthful, so which is why we call it the options study, but optimising the treatment of infection in the critically ill neonate through application of innovative microsampling approach. So where we landed with this study was the use of volumetric absorptive microsampling devices, also known as VAMs. And the little picture down the bottom there you can see is a little VAMs tube. They come in a little pack with a lovely little purple container. And the absolute brilliance of these microsamplers is that they only require 0.01 mils of blood. And if you recall earlier, for our standard samples at the moment, we're using up to 0.5 of a mil. So it's a significant reduction in the amount, and can be taken from simply a little drop of blood, much like you would use a blood glucose monitor. And it's a very similar technique to how we use those. So this dried blood specimen that sits on at the end of the VAMS tube there is then able to be used for analysis of drug levels. So that little hydrophilic tip there absorbs a fixed volume of blood, and it's very easy to use. You simply get the drop of blood from whatever means you're taking it, whether that be a heel prick or a venipuncture or an arterial sample. So however the nursing staff would normally take a gentamicin level, you can use the VAMS sampler to do it in the same way. And all you have to do is just place it just over the bubble of the blood, and it wicks up into the hydrophilic tip. That's actually an actual sample that was taken from a patient in the study. Or was that one that you took from your own finger, Susie? I can't remember. That was a patient. So what the option study looked at doing was seeing whether this was actually something that was viable for use in the nursery. So the design was to look at microsamplers and compare them to our conventional sampling techniques, and then analyse those for a comparison to determine if the gentamicin level that was taken via the microsampling device was equivalent to our standard approach. And therefore, hopefully to demonstrate that there was a role for microsampling techniques in the neonatal population. So I won't talk too much about the results, except that they were excellent, and Susie certainly can talk to that at the end. But what I did want to talk about, and I guess this was sort of more from our side, from the neonatal approach, was whether the nursing staff and those caring for the patients actually thought that these microsamplers improved care. And I guess part of the nature of implementation science is that you can do all of this research and prove all sorts of things, but if people aren't going to use it, then it's not actually useful. So this is an important survey. We thought it was great, but did everybody else think that it was great? So the nurses that participated in the study completed a questionnaire about their satisfaction using the devices, using a fairly simple questionnaire. And they were asked about their perception of the VAM sampler versus their standard care, and whether they thought that it improved the care for the neonate as well. So whether there was a perception of pain for the neonate during the VAM sampling method. So it was actually 50% perceived that the microsampling was less invasive and less painful. I guess the difference here is that you still, if you're taking a conventional sample by a heel prick method, you still need to prick the baby's heel for a VAM sample. But certainly the difference is that we don't have to milk the blood out to get a 0.5 ml sample like we would with a conventional sample, which certainly causes babies pain, and many babies are left with quite bruised feet and heels after those procedures. But 100% of nurses agreed that they would recommend the microsampler. They all thought that it was less invasive than standard care, and they all felt very confident using it, which told us that it was something that was easy to use and was liked by the nurses, and would certainly in that way have a greater sort of chance of being implemented into our routine care. So I guess it comes down to where to next with our study. And as I said, Susie may be able to answer some questions if you have more detail about the results of the study. But if we're able to demonstrate that microsamplers themselves are effective for therapeutic drug monitoring and therefore antimicrobial optimization in our neonatal population, then the doors are sort of opened for all sorts of other uses. So there's other drugs that we use very frequently in our neonatal nurseries, like vancomycin and meropenem as other antimicrobials that we often do therapeutic drug monitoring on. But this could be potentially expanded to the use of any sort of drug that you may need to do therapeutic drug monitoring on. And that may include things like phenobarbital that we use frequently for seizures. So I think that there's certainly some excellent research and progress to come. And I'm looking forward to seeing what Susie and her team might have in store for us in the future. So thanks very much.
Thank you very much, Fran. Just in follow-up, yet the results were really promising for the use of VAMs for TDM in measuring gentamicin, and we hope we'll be publishing that data soon. It certainly was able to meet the FDA criteria that we were seeking.